Welcome back to Breathe Easy. This is episode 32, and today we're on the letter C of the A through F bundle, choice of analgesia and sedation. We call this one comfort without the cloud because there's a difference between a patient who is comfortable and a patient who has simply been fogged over. Peaceful and comfortable are not the same thing. That's the whole episode. One quick note, everything today is educational. It does not replace your facility policy, your provider orders, or your own bedside assessment. Let's go. Here's where we're headed today. What the C element means, analgesia first before we escalate sedation, using RASS without chasing the number, matching the medication to the mission, and why two patients can get the same drug and look completely different an hour later. That last one is where this stops being a guideline recap and starts being about the actual person or patient in the bed. Here's what we want you walking away with today. Why analgesia first and light sedation move patients toward liberation. How to use RASS as a shared language without letting it replace your eyes. What changes a patient's response to these medications, and how to consider local context. For example, in North Carolina, we have Lumbee Indians that are around the Lumberton, North Carolina area, and there's a lot of research and pain research as a reason to individualize care, never as an assumption about a patient. Quick walk down the alphabet. A. Assess pain and treat pain. B. Wake up and breathe when it's safe. C. Choose analgesia and sedation on purpose. D. Reduce delirium. E. Move them. And F for family. Look where C sits, dead center. C is the hinge. Get it wrong and you don't get just C wrong. Too deep and B gets harder. D gets worse and E may not even happen at all. So here's the goal. Comfortable, arousable, synchronized, and able to join their own recovery when it's safe. Treat the patient, not the RASS score. Run your eye down the scale. Combative at the top, alert and calm in the middle, lightly sedated just below that, unarousable at the bottom. PADIS points toward light sedation rather than deep sedation in mechanically ventilated adults when it's clinically appropriate, because that's what lets a patient participate in an awakening trial, a breathing trial, and move. But here's the trap. A score is easy to chart and easy to trust. You can document textbook light sedation on a patient who's in real pain. The chart is satisfied. The patient is not. So say the target out loud during your rounds with the other disciplines, and then keep looking at your patient. Here's a favorite question of mine. Is the pain wearing an agitation costume? Agitation is a symptom, not a diagnosis. And the reflex we all fight is the one that reaches for the sedation. So before it's escalated, if the patient can tell you, ask. Self-report is the reference standard. If they can't, use CPOT or BPS and watch the trend. Check the mechanical causes. The tube, shortness of breath, asynchrony, could it be positioning? Treat pain before adding sedation. Then reassess and document. And the pearl, vital signs are not a validated pain score. A rise in heart rate is a cue to go assess. It is not the assessment itself. Match the medication to the mission. Analgesia comes first with multimodal adjuncts where appropriate. Propofol is on fast, all fast, easy to titrate. Watch hemodynamics, triglycerides, and propofol-related infusion syndrome. Dexmedetomidine is your interactive option, also known as Precedex, where patients can rouse and participate. Watch for bradycardia and hypotension. Benzos, avoid routine infusions when you can. PADIS suggests propofol and Precedex over benzos, and the 2025 update leans to Precedex when light sedation or delirium reduction is the priority. 3 questions for rounds. What is the target? Why this agent? And what can make us change the course? 2 patients, same medication, same dose, completely different response. Why? Age and frailty, renal and hepatic function, drug interactions, prior opioid exposure, substance use history, critical illness itself, which changes volume of distribution while you watch, and pharmacogenetics, where literature describes real variability in analgesic response tied to metabolism and genetics. Then the human layer, family comfort cues, cultural context, including lumbar pain research closer to home that's been done at UNC Chapel Hill. That is a reason to individualize, never a reason to assume something about a patient. None of that is a reason to guess. It's a reason to assess, titrate, and reassess. Here are some words you can actually use at the bedside. For your comfort goal, our goal is comfort and safety, not keeping your loved one more asleep than they need to be. For pain cues, what signs tell you your loved one is hurting? Families know the flinch, the jaw, the particular stillness. For preferences, are there practices, support, or communication preferences we should know about? And for light sedation, if it's safe, we're aiming for awake enough to interact, breathe, and participate. Then document it next to the RASS target and daily sedation plan. If it isn't documented, it didn't survive the shift change. Let's put it together. Middle of the night, a ventilated patient becomes restless, slightly agitated on RASS with a CPOT of 5, and the family tells you this patient goes quiet rather than verbal when in pain. Do you increase the sedation, assess and treat the pain first, review the RASS target, consider patient-specific factors? The answer is all of them, but treat the pain first. That CPOT is a positive pain signal, and PADIS tells us to treat pain before reaching for sedation medication. Reach for the drip first, and the agitation disappears while the pain does not. The room gets quiet, and the patient keeps hurting. Let's land the plane. Here's what to take with you. Treat pain first. Use RASS to communicate the target, not to replace judgment. Choose based on the patient in front of you. Let population research deepen your curiosity, not create assumptions. And remember, the best sedation plan helps a patient heal, breathe, think, move, and participate. Comfort without the cloud, not absent, comfortable, not silenced, supported. One assignment on your next shift, be the person who asks, have we treated the pain before anyone goes and starts touching sedation? Thanks for spending time with me today. This has been Breathe Easy. Take care of your patients and take care of each other.